intestinal and a couple extra intestinal, or in other words, they won't actually ever even go to the intestines. And a lot of the worms that we're talking about at the moment, they kind of have a large intestinal tract component to them, but not all do. So we're going to hit a couple here that do not. And if you guys want, I can curve out all of the extra side quest stories as well. Nematodes, unsegmented worms, free living. They do have a mouth, a gut, and an anus. They don't necessarily hook on all the time like some of them do. Strongyloides is the first one we're going to talk about. Man, this sucks. I'm sorry, guys. Can you guys see it okay? Good enough, at least. Follow along. Did it download into a PowerPoint on your computer from Canvas?
Yes.
So it's just me. That's cool. And I don't mean that like sarcastically. Like I'm glad that it is just me. Okay. Strongyloides is the one that we're talking about. A lot of these that we're talking about, these nematodes we're talking about, they are just kind of free living in the soil. And as people walk barefoot on that soil, beaches, farming, just around the ground or whatever, it will migrate up through the skin and into the system, find its way into the blood system, and use the blood system to get to the lungs. When it's in the lungs, it will kind of then migrate through some lung tissue or end up in the trachea. People cough them up and not always get to spit them all the way out. They will swallow some, and then they'll end up back in their own intestinal tract. When it's in their intestinal tract, they grow, hatch eggs, that then grow through their intestinal tract, back to their lungs, they cough up, spit them back, and they call that autoinfection. We'll talk about that, but that's a lot of the worms that we're talking about in this section will do. So, they live in the soil, they penetrate bare feet, they travel through the blood to the lungs, kind of just what we said, as you see on the screenshot here. And then the eggs in the feces, a lot of them will be dispersed onto the ground, which will then grow on the soil, and other people will pick them up. You can kind of see a description here of the life cycle. Somebody brought up a question to me the other day, this picture of the life cycle. I actually kind of find these ones relatively helpful because it kind of helps me like visualize where they're living, where they're going, how they get into the body, how they move around. However, I'm not planning to ask you any questions that ask what section of the life cycle are they in the feet or whatever the case is, right? We're approaching this from a clinical perspective, so let's work on teasing out physical exam findings, history findings, diagnostic criteria to help diagnose it, and of course treatment and follow-up. That's what we're going to focus our efforts on here. I don't always think that learning this stuff is super helpful. However, in the parasite section, I found it pretty helpful, so I left them in there. If you find them helpful, great, and if not, you don't need them, that's awesome as well. All right, some GI symptoms, not always super present. People don't always know they have them, or they're relatively asymptomatic. When it gets into pulmonary symptom, you can get what's called Leffler's syndrome. If you look at what Leffler's syndrome is, it's commonly related to parasitic infections, but not always. Basically, it's excessive eosinophilia of the lung tissue. Are you guys familiar with eosinophilic esophagitis? Have you heard that phrase yet? So think a similar picture, but now it's lung tissue, just kind of caked full of eosinophils instead of trachea. You can get a lot of pulmonary infiltrates and stuff like that. So during the pulmonary portion of this strongyloides, Leffler syndrome can happen, and you'll recognize a lot that we talked about today has a pulmonary component, and all of them can kind of have potential to create this Leffler syndrome. Dermatologically, there will be a lot of urticaria and a lot of rashes. In fact, we'll see one that actually just simply stays in the skin itself. It doesn't actually transmit to the blood, the lungs, or the gut. As it starts to work its way around the body, most of these really don't have a limit to where they can go. We just kind of have commonalities of where they go. In this case, even meningitis and sepsis is possible, and eosinophilia can be present in acute or disseminated stages. To diagnose it, microscopic identification of the larvae is preferred. Look at this second sub-bullet down, entero test by a string, or the string test. If you see or hear that, what it's talking about is it's a relatively non-invasive test. An individual concerned for this will take basically a capsule that's hooked onto a string and swallow it. When it's in the stomach, that capsule dissolves and kind of like allows more of that string to be dispersed and go down through the gastric compartment into the duodenum, and it just sits there for a certain number of hours. This string is absorbing that gastric contents. And then they will pull that string back out and then observe it for the larvae because it's living a little bit higher up in the system. So you'll hear it called the entero test or enteric system test or the entero string test, or if in context, this is a topic and you hear people say the string test, that's what they're referring to. So they swallow the pill, that pill is for the most part dissolves, and at that point the string kind of does its job, and they kind of gently pull it up. Once it's diagnosed, so anti-helminth or antiprotozoals like ivermectin or albendazole are good options for this one. All right, hookworm is where we're going next. Typically found in tropical and subcutaneous regions, lives in the soil, penetrates the bare feet, just like we talked about that, travels through the blood to the lungs, then to the trachea, they cough it up, they swallow it, and then it gets into the GI system, attaches to the wall. One of the things that's pretty important about hookworm, and we'll talk about a little bit, is it tends to cause anemia and a lot of malabsorption and malnourishment with patients who have hookworms. So you can kind of see through here, gets into the skin, travels up to the lungs, then auto-infects itself into the GI system. A lot of people will get something that they call ground itch, and that's at the site of where the actual worms entered the body. They can get a pneumonitis, so inflammation of the lungs, and they get intestinal upset or GI upset. We don't talk about a lot of very specific things. A lot of it's overlapping, so when you see something specific, I highly recommend kind of circling it, highlighting it, whatever you do. With hookworms, people can become iron deficient anemic. And so they'll get a lot of malnourishment and then be iron deficient. You guys remember from Clin Lab what type of anemia we typically see with iron being low? Micro, macro, or normocytic?
Micro.
Typically microcytic. So the MCV below what number is typically associated with microcytic? Below 80. Usually below 80. And that's, I say usually, I can't speak for any other course. If you happen to see a question like that, I'm not telling you will, on my test, I'll make it pretty obvious for you, right? But I've seen a lot of situations where just in clinical context, people will see that they're anemic, their H&H is low, they'll see the MCV and it'll be at 81. They're like, oh, what do we do? What is this? And then they'll still typically order an iron panel and start empirically on iron because iron deficiency anemia is so common and it tends to cause microcytic anemia so easily that a lot of people will kind of softly adjust that threshold in clinical practice. But I think the normal standard is 80 to 100 on MCV size is normocytic. Is that what you guys were taught? Below 80 is micro, above 100 is macrocytic. So whatever you say, Mr. Teacher Man, because when you're done, we get to go home. What's that? Yeah, you like that? I can say pretty words, but I can't figure out what dinner is every night. Nobody told me that being an adult, I'd have to figure out dinner for the rest of my life, right? Like I now know why my mom had 5 things and we just rotated through them. Pica is a possibility. You guys remember talking about pica at all from psych? Sometimes people will talk about it a lot. Sometimes they'll just kind of let you learn it. But pica is describing a situation where people have this desire to eat non-food substances, whatever that is, soil, metal, wood, stuff. There is some thoughts out there that people with a diagnosis of pica have a malnourishment, and that's their body's way of trying to find that nourishment, whatever that vitamin or element is that they're low on. There's really never been anything to my knowledge that proves that that's what pica is, because it could be a psychiatric condition as well. But in this case, these individuals become malnourished, have a iron deficient anemia, and some of them may have this tendency to chew on non-food substances and protein malnourishment as well. All right. To diagnose it, microscopic identification of eggs. The larvae are helpful as well. Treatment-wise, albendazole and mebendazole are great. Underdeveloped countries, this tends to not even get treated. You can see how small these little tiny worms are that are attached to the intestinal tract. Ascariasis is the next one we're going to talk about. Ascaria lumbricoides. Worldwide, but tropical countries in southeastern U.S. tend to have a large disposition of them. Fecal-oral route. So this one's not coming up through the feet. They'll actually ingest something contaminated, ingest eggs into the larvae, penetrates the wall, takes the blood system to the lungs again, and that auto-infection can happen again. Typically not a lot of acute symptoms. If there is a high worm burden, people might get some type of abdominal pain and can even get an obstruction if the worm's just overgrown. If those worms migrate and they migrate and obstruct a lumen that needs to stay open, we kind of talked about this with another condition, the appendix or the gallbladder or something like that, you could end up with a secondary cholecystitis, cholangitis, appendicitis if it's obstructing the wrong way. My brain immediately goes to some of those commercials for heartworms for dogs. Have you guys ever seen those where like the actual heart is just like so caked with worms that blood can't flow through it? Ever see that? That's kind of the same picture that's going on here. The intestinal tract is so packed full of worms, there's really not a lot of nourishment that can happen, and it can get easily obstructed. Some diagnostic options here. A microscopic identification of eggs in the stool, typically pretty common. You see the word barium here. Do you guys remember talking about a barium swallow or barium follow-through in radiology? So if you have somebody drink some barium and you wait till it's in the GI tract, we should, on x-ray, see that barium fill up all the corners and the curves of the GI tract, right? So if we see where that normally should be, and now all of a sudden it's really condensed or thin, there's something obstructing it and not letting a lot of that barium through, and so we could see some of that. Albendazole and mebendazole are good options. Look at the worm burden inside that intestinal tract. And then here's a picture of this barium study. And you can, they gave us a positive circle sign, right? Like the red circles tell us what to look for. But you can see the hypodensity there where these worm burdens are. And you can see that barium should be filling up all those nooks and crannies of that GI tract, and it's just simply not. Enterobiasis is the next one. Anaerobius vermicularis, also known as the pinworm. The pinworm gets a lot of attention, especially in America, because one, I think it's the most common, if not one of the most common, but it's so easily transmitted, especially through kiddos, because the female will travel at night to the anus, lay its eggs on the anus, so it's incredibly irritating, and little kiddos are a little bit more willing to scratch things that itch than adults are. I don't know, maybe adults are too, don't know. But they'll get the eggs of the pinworms in their fingernails, on their clothes, and then spread them like crazy. Very small too. Did you guys see the size of that? The adult is 8 to 13 millimeters. Millimeters are small, they're not very big. And adult male, 2 to 5 millimeters. So what is that, 10 millimeters per centimeter? So a 2 millimeter male is 1/16 of an inch, something like that, pretty small. All right, individuals will orally ingest the eggs. They mature. After mating, female pinworms will travel to the anus. You kind of see it in the middle of the slide there, usually at night. And so the patient or the person infested with them will end up in this like late evening, early morning time frame with this really intense anal pruritus. And a lot of times either on purpose or an accident because they're sleepy, they'll just start itching their behind. And if they don't clean their fingers well or the behind well, now all of those eggs are in their hands and their fingers and can be transmitted pretty easily that way. That perianal pruritus, especially at night, very classic symptoms. Excoriations can happen. People just itch like crazy because it itches like crazy. And that skin that's already very irritated from the infestation now just becomes more inflamed and irritated and chronically traumatized by the scratching from the individual. And then look at this fourth bullet down. It can even potentially invade the female genital tract from fistula formation. So when you have two openings next to each other, so example, the vaginal canal and the rectum, right? They're not separated, especially in the female anatomy, by very much tissue. And by the time that tissue gets to become inflamed, chronically scratched, and all the inflamed tissue kind of starts to like agglomerate, it can open up these little unrecognized tracts between them, and you could end up with stool flowing into the vaginal cavity and such. So some patients can end up with a rectovaginal fistula just from that chronic inflammation secondary to the pinworm infection. Granulomas are a big old beefy skin condition. Again, it's just that chronic inflammation and that parasite getting that skin and just kind of like irritating it and living there. Look at this one. Rare but possible appendicitis. We already talked about that a little bit, right? Like, okay, it can travel somewhere and obstruct the lumen. But another lumen that if it is close enough, especially if a rectovaginal fistula is present, it gets in the reproductive tract of the female anatomy. What is the salpine or the salpo? What does that refer to? The fallopian tubes. So can you imagine pinworms traveling all the way up through the uterus and then into the fallopian tube so much that that's irritating it? Yeah, very, very uncomfortable. So salpingitis would be like wildly problematic. All right, to identify it, microscopic identification of the eggs, especially from the perianal area. And this is where the famous Scotch tape tests it comes from. Has anybody heard of that before? People talk about it. It's kind of a, I don't say homeopathic, but a lot of people will do it. So there's a formal diagnostic tool. It's like this little paddle, and you peel off a little protective film, and there's this little sticky paddle. And then what will happen is, like a parent of a kid that might have pinworms, whatever, they'll wait till the morning time. They'll kind of spread the butt cheeks around. They'll take that little paddle and touch it around the skin of the anus. And if that female pinworm has come and deposited their eggs, I think over 10,000 per night is the estimation, they should be able to take that little big piece of adhesive tape, put it on the microscope, and recognize the eggs. Sometimes if they don't have the actual collection tool, they'll tell people, just take Scotch tape. Make a little circle of Scotch tape with the sticky side on the outside, put it on your fingers, and just touch around the skin of the anus, and that's just as adhesive as the tool, and then turn that into the lab, and they'll be able to look at it under a microscope and see if they see any of the eggs. And it says multiple exams might be necessary, and it's because the individual collecting the sample may have just accidentally missed it, or weren't a heavy egg burden that day, or whatever the case is. So if the clinical suspicion of pinworms is high, and the first test or two, the Scotch tape test, is still high, and you don't get a positive result, doing it a couple of times in a row before confirming that it's negative might be a wise idea. All right, anaerobiasis, same one, mebendazole, good family education, so once we can get rid of or get under control, the more that we can do to keep it from spreading to others is ideal. Okay, those are ones that had an intestinal component to it. The next ones that we talked about have a non-intestinal component to it. Some of them completely non-intestinal, but not always. But these ones tend to leave the intestines a little bit more aggressively. Our cutaneous larva migrans, Ankylostoma caninum. It's like a hookworm. It penetrates the skin. However, this one just stays in the skin. And it's a clinical diagnosis. Once we see it and it matches the clinical picture, we usually just diagnose it and treat it. So again, walking barefoot somewhere, there's intense pruritus, and they have these linear lesions that advance. In this context, the word advance doesn't mean get bigger, it means they're actually moving around. So it'll get in the skin, and it'll move around. Anybody when you were kids, I'm pretty old, so like you young folk may not have done this, but we would used to take like safety pins and needles, and we would like put them into our skin so that it was just underneath that surface skin, and we would freak out our teachers or whatever. So to me, that's what this looks like. It is just underneath enough of level of skin that it's not escaping the skin, but it's not getting deeper into the dermis tissue or the muscular tissue, subcutaneous tissue. And so hence the name actually fits this diagnosis pretty well. Cutaneous larva migrans stay in the cutaneous tissue. This larva grow into worms, and they just kind of migrate around. So if you have the history that matches it, you have the exam findings like this picture that matches it, and then the next day you see that it's moved a little bit, it's pretty diagnostic at that point. And then if you look at this life cycle, you'll recognize kind of even in the picture of the diagram of the individual, it stays on the skin. This one pretty much stays on the skin of the individual. It doesn't really go much deeper than that one, but very irritating, very itchy. There's a nurse somewhere that looked at that picture and said, I can hit that vein. Any nurses? Okay, thank God. I mean, just whatever. I love nurses. I love nurses. I was about to tell you guys a side quest story, but I won't. All right, let's keep going. Cutaneous larva migrans. So diagnosis, usually a clinical diagnosis is all it's need. We don't have to stick this foot under the microscope because we can see it. It meets the clinical picture as well as the manifestations. And albendazole and ivermectin are pretty good at taking care of this if needed. All right, toxocariasis. It's a dog roundworm. Sometimes it can be from cats as well. And this one causes visceral larva migraines. What's the word visceral mean? What's it refer to? Organs, right? And so cutaneous larva migrans is something that lives in the skin and migrates around. What do you think visceral larva migrans does? Migrates from organ to organ. That's organs all over the body. It's real bad. Ocular, what part of the body is that referring to? It gets into the eyeballs. And so you know where the retina kind of like smashes against the back of the eyeball and it causes all of those nerves and arteries? These worms will get between the retina and the actual posterior section of the eye and start to separate the retina from it. It's pretty wild. See the diagram here, carried throughout the body. All right, it can be asymptomatic, it's possible. Visceral larva migraines, it kind of depends on what organ is being infected, but some kind of overall generic information here. Hepatosplenomegaly, it can definitely get in the liver and cause it to be inflamed. The ocular larva migraines is pretty heartbreaking. They cause these ophthalmic lesions, and you can just look at this, right? You can see that whiteness right in the middle. Unfortunately, a lot of times this gets misdiagnosed as a retinoblastoma. So think of the clinical skills class you had. Remember when you were like, red reflex is present. You didn't really know what you were looking at or why you were saying it, but you said it so you can get the points. Exactly. So the reason that you're looking for a red reflex is to see if a really healthy retina is in place and just doing its job to kind of reflect light appropriately. If you were to have looked through that ophthalmoscope into the pupil and you see this big white circle or this whiteness, in other words, a red reflex wasn't present, it doesn't automatically mean it's a retinoblastoma, but a retinoblastoma is kind of the classic thing we're looking for there because it's so bad. In this case, if this individual has ocular larva migrans and it sits in the back of there, it can be inadvertently diagnosed as retinoblastoma. And what do they do with retinoblastoma? They enucleate the eyeball, and they find out later they didn't need to because it was just a parasite infection. So this accidental surgical enucleation, what it's talking about there is they intervened on what they thought was a blastoma, and then afterwards, after they enucleated the eye, took the eyeball out of it, they found out that it wasn't actually a retinoblastoma. So this patient's, I'm assuming left eye, right side for us, you see how that red reflex is not absent, it's got that whiteness deep to what that pupil would be. That would be an example of what you might see when you were checking for a red reflex and it was not actually present. All right, toxocariosis, there's no findings on an O and P, and it's a pretty clinical diagnosis. Remember, this is an extraintestinal one. So albendazole and ebendazole are good options for it. Trichinosis or trichinosis, you guys heard of this one? This one actually gets enough recognition. It's not super uncommon. If you have any idea where, or you guys remember where you typically hear it from? This is, what's that? Say it one more time. URI, like upper respiratory infection? UTI. No. No. So trichomoniasis is different than trichinosis. So contextually speaking, if you have a female patient, sexually active, and has a thin white discharge, trichomoniasis seems really likely, right? If you have somebody who has been camping and or hunting and decided to kill a bear and eat its meat, you might have trichinosis or trichinosis. So trichinosis is still a parasite. It lives in a lot of animals. In the North American areas, usually bear and boar or pork tend to be the carnivores that it lives in. So the classic story is they'll get killed somehow, typically through hunting. They'll go to eat it, but they will not properly cook it, and they won't actually cook it to a high enough degree to kill the trichinosis. And so then the humans ingest it, and then they get a trichinosis infection. Does anybody watch the show Meat Eater or heard of it? So it's a hunting show. It's a little bit newer in style than like the 90s, everybody sit here watching me hunt for 8 hours on this ravine and I might shoot an arrow show. This guy is actually wildly intelligent on wildlife, and it's almost like a soothing tone to the way he describes things, and so it's pretty cool. It's kind of like the Bob Ross of hunting. It's just enjoyable to watch. But if you ever watch that show, it's on Netflix, they talk about trichinosis a lot because their community of people and friends is all hunters. And so a lot of individuals that they know have ended up either with chronic wasting disease, which we're not talking about, or trichinosis because they've eaten under processed, undercooked bear. Say that again? Lyme disease is all over the place as well. So Lyme disease, we haven't talked about it yet. It's another one of those great mimickers because depending on what stage you catch it and what part of the body it's affecting, it can look like so many other things. But we'll stay with trichinosis for the moment, or trichinosis. So if it's intestinal invasion, you can kind of expect the normal intestinal symptoms. If it migrates, it can go to the eyes, conjunctiva, muscles, skin, kind of the heart, central nervous system, all over the place. It just depends on where it goes. Here's a picture of what splinter hemorrhages look like. Have you guys talked about splinter hemorrhages in cardio yet? It's microscopic blood clots, right? That just go to the most peripheral possible small arteries, so you might be able to observe them. And look at that conjunctivitis. Look how gnarly that looks. So it's a pretty big deal. Trichinosis, nobody wants trichinosis. I mean, I don't know of any of these infections that I do want, to be fair, but trichinosis is one that tends to strike a lot of fear in individuals. Usually a clinical diagnosis, however, some labs are familiar with these, eosinophilia, EIAs, muscle biopsies, and CTs for imaging can possibly be there as well. If you have severe symptoms, steroids might help, and albendazole and mebendazole are pretty good options there. So, there we go. Any questions on that? We need to get through one more lecture. It's not a difficult lecture. I'm guessing 20-25 minutes. Push or take a break?
Push.
Push. Okay. Protozoal infections is what we're going to worry about. Let me just make sure that you guys are seeing something good up there. All right. Here are the ones we'll talk about. Malaria, even though it falls under this, malaria gets its own lecture. So we will talk more about malaria in depth and the different versions of malaria next week. All right, what is a protozoa? It's highly motile, moves pretty frequently, unicellular eukaryote, usually predatory or parasitic, moves by cilia or flagella. It has this amoeboid motion, maybe aquatic or might be terrestrial. So I'm going to kind of restate all of this. It's this little tiny glob that moves easily, that's a predator that can be on water or land. That's nightmare stuff right there. So that's what we got with protozoa. Amoebiasis is the first one we'll talk about. Entomobia histolytica. If we look at the name of this one, the name kind of describes what it does. The word histolytica, the first part of it is histo. Do you guys remember what medical tissue or cells? Lytic, L-Y-T, or lit, does what to cells? Destroys them. So this actually gets into cell tissue and breaks them up into smaller pieces. This actually destroys the cell tissue. All right. So you can kind of see there, it exerts this lytic effect. It induces self-destruction of whatever organ it is in. Usually it gains access through circulation to the liver, the lungs, or other sites. And the liver, and of course the liver's companion a lot of things, the spleen, tends to be affected pretty commonly. If it gets into the GI tract, you can get an amoebic colitis, abdominal pain, diarrhea, bloody stools, and eventually, if it's bad enough, it can turn into a fulminant colitis. And again, a possibility of some type of a rectovaginal fistula just because of the chronic irritation, the weakened skin down there. It is possible for a sinus tract to present between the colon and the vaginal canal. It is even possible for this amoebic to create an amoebic liver abscess, fever, right upper quadrant pain. If it's a single abscess, there could be weight loss. And then, of course, you may even be able to tease out some history of dysentery in the last year. Talking about the colitis versus the liver abscess, just some common symptoms you'll see there. a lot of this should make sense, and so a lot of the history and the exam diagnosis will be here. Really important here. You'll see this first statement on several of these slides, and then enteric parasite panel, or EPP. This is, have you guys heard the phrase like thyroid panel, liver panel? Yeah, you've heard that before. Everywhere that you go, every clinic that you work in will have either panels already made in terms of lab orders, or you can sometimes even customize your own panel. Let's say that you've got a series of things you like to order for a specific concern or whatever. You might be able to, within your electronic medical record, build your own panel. So this enteric parasite panel, it's pretty ubiquitous, but it might be a little bit flexible based on where you're at. So this kind of goes into, like we normally say whenever you get to the hospital you're working at, if they have an enteric parasite panel, look at what's in there, what it's being tested for. But a lot of these we will pull, and if you just simply order this panel, it'll be looking for different parasites that are found inside stool. So it's a stool test, it's a PCR of that stool test to look for different parasites that could be possible as well. You can do a stool antigen test, an O&P, an ultrasound, and a CT, just looking for signs of the amoebiasis in the tissue. Metronidazole, tinidazole, iodoquinol, and paromomycin are good options for this. And then if you have a true fulminant colitis that is fully inflamed, surgery intervention may be an option as well. The reason that you'll see lists like this that say differential diagnosis, I will never ask you a question. I can't speak for other instructors. I will never ask you a question that says, what is on the differential for this? That's an unfair question, and it's really not value added. The reason you see this here is because if you start to think of what we just talked about, it can start to kind of overlap in symptom presentation. There's other things on the differential. So there is a lot that's going on here that could be there. So there's got to be something that sticks out when we are looking at these different diagnoses that helps us delineate them from something else. All right, giardiasis. Anybody watch New Girl? That's what I'm talking about. Probably the best show ever created. What's that? Somebody said it. It's just right. So there's a very famous episode where two girls are fighting over a guy and says, well, he gave me giardia, so I saved you from a terrible river disease. New Girl got me through a very difficult time in life called phase 1. All right, giardiasis. Giardiasis, it's again an amoeba. It's a fecal-oral route. However, this one tends to have a predilection for contaminated water sources. So if out of a history you kind of tease out these individuals were hiking, hunting, walking around, and they decided to drink out of a river, and then all of a sudden they get this really sick illness, GI illness, it could be giardiasis. Not completely understood. There tends to be an epithelial structure function condition to it, where it distorts the microvilli inside of the intestinal tract. Then it might even release some cytopathic substances. Let me go back a slide or two. And you can look at these symptoms. A lot of it is GI symptoms, but for whatever reason, with giardiasis, a lot of flatulence and malodorous, frothy, greasy stool that might float.
Hell yeah.
Right, exactly, like ew. So it affects the GI tract and the normal process of the GI tract pretty significantly. Usually on physical exam, no specific finding. Again, there might be some tenderness, a lot of history, and a lot of history is pretty important with giardia. And that enteric parasite panel might help as well. There are some imaging. For example, like here's another example of a barium follow-through. Do you guys see how limited that barium is inside that GI tract? Normally that should be quite full and filling up all those diverticula, etc. But it's not because it's being impacted with giardia. Tinidazole or metronidazole, there's not really a good surgical indication here, and sometimes it resolves spontaneously. All right, leishmaniasis. Leishmaniasis is found in a lot of countries. We're going to divide leishmaniasis into a couple different parts. One is cutaneous, and this is where the parasite creates this really massive ulcers on the skin. And then mucocutaneous, or in other words, mucous membranes, visceral, and viscerotrophic. In other words, below the organs. It's a zoonotic disease and is transmitted by sandflies. So in countries or areas where these sandflies that carry leishmaniasis are present, much more likely to run into it. All right, the two forms, so we're a couple of slides down the road here, slide 30 of 69. Cutaneous and visceral. You see in parentheses it says Kala-Azar right there. That's just another name for visceral leishmaniasis. So if you hear somebody say Kala-Azar disease or Kala-Azar leishmaniasis, let's talk about visceral leishmaniasis. All right, cutaneous lesions. This happens at the actual feeding site from where it was impacted or infected at. It can be one or more sores. And then look at the fourth sub-bullet down, raised edge with a central crater. I'll show you a picture of it here. This is real obvious. This isn't something that's meant to be like difficult to see. If you have somebody who is bitten by a sandfly in an endemic area and you see something like this, cutaneous leishmaniasis should just absolutely jump to your differential. A couple pictures here of some cutaneous leishmaniasis. All right, moving over to visceral or Kala-Azar leishmaniasis. Some people would call it black fever. This is a much bigger systemic type of situation. It can get into the liver, spleen, bones, pretty much any tissue that it wants to, it can get into. Hepatosplenomegaly tends to be pretty common in this, and it is also an opportunistic infection for HIV patients. We already talked about the cutaneous, but this slide is talking about when you have visceral leishmaniasis, there can be associated dermatosis with it as well. Very similar presentation. These individuals that have the visceral leishmaniasis, fevers, hepatosplenomegaly, wasting and weakness, can be darkening of the skin, maybe even some diarrhea or pancytopenia. You see this little patient here, pretty distended belly. You see that marking on their skin right there? That is somebody who has taken a skin marker and actually traced the size of where the liver and the spleen is. Much more probably just for the picture, so that we can kind of use it for us to learn off of. I don't know that they were tracking size or growth of it like they do with a lot of skin marking, but either way we get to benefit from it. Just quick question, should the liver be that big?
No.
No. You guys remember when you're doing clinical skills and you're like, liver is measured at 4 centimeters at mid-axillary line, and you're like, why do we have to memorize this? This makes no sense. This gives us an example of a normal range. That if we do have a liver that measures much bigger than that, we can wonder why that it has hepato or splenomegaly. You can see another just huge. Let's just kind of play with this. Let's see if we got this. Did the laser pointer just show up on the screen? Yep. What up, dude? Okay. This line right here, that's the spleen. And then you see up the our upper left corner of the patient's right upper quadrant corner, that's the liver. So when you hear somebody say hepatosplenomegaly, this is a pretty robust example of hepatosplenomegaly. More pictures of the same here. All right, isolate the organism from tissue is a great way to help diagnose it. Giemsa stain might be relevant, serology, ELISA culture. And then when you see cutaneous lesions, a lot of times that clinical picture may be the diagnosis. To treat it, you get some descriptions there about certain times to treat it. Paramomycin might help. It's under investigation for it. Liquid nitrogen is a lot of times in this like little spray can. You can spray it on the skin to destroy lesions. A lot of times it's like a warty lesion or a possible skin cancer type lesion. But in this case, it's considered to help the cutaneous leishmaniasis as well. More aggressive therapy, if it's on a face or cosmetically sensitive area, might be more aggressive with it. This is some examples of that. And sodium, I have to practice this one. Stibogluconate, hard to get. It's not FDA approved. It's under investigation. There's a couple here that are under investigation as well. Liposomal amphotericin, that's not under investigation. That's one that we get. Miltefosone, fluticasone, thermomed radio frequency, all attacking the skin and or systemic infection. All right, differential there. You guys haven't had derm yet, so you guys have learned about basal cell carcinoma. Basal cell carcinoma has this kind of like classic appearance of these heaped up lesions on the borders with a central crater. And so I think leishmaniasis is quite a bit bigger than what a basal cell would look like, but there is an overlapping kind of quality to it. Cryptosporidiosis. Have you guys talked about crypto at all so far in this one? What are we talking about crypto for? Is it an AIDS-defining illness? Or related to HIV and AIDS? It's an opportunistic infection. So somebody with a weakened immune system gets exposed to crypto. It can wreak havoc in that body because the immune system can't fight it off. And so now we're going to talk about actual cryptosporidiosis. All right, people get it from contaminated water, highly infectious, and the oocytes are super resistant to water treatments. And so if it happens to be in water, that even water that's been treated, it might not have killed all of the oocytes from cryptosporidium. Typically limited to the jejunum when it's healthy. However, they can get into the entire GI tract of somebody who is immunocompromised. A lot of it can be asymptomatic. Typically, if we have somebody who's exposed to crypto and they're immune competent, typically not a bad case. A lot of times they may not even come in to get seen, but somebody who is immune compromised, typically more impacted and much more likely to come in for help. All right, on physical exam, pretty non-specific findings. They might have a little bit of epigastric or right upper quadrant pain because it does tend to hang out a little bit higher in the GI tract. If it does impact the higher GI tract and gets into some of that hepatobiliary system, you might get a little bit of icterus or some ascites. Again, that EPP or the enteric parasite panel can be helpful looking for things living in the stool. Treatment, if you have an immunocompetent individual, a lot of times supportive care is really all you need. Immunocompromised, there's really not a great antibiotic treatment or antimicrobial, but if you do have somebody that's like an HIV patient going on some type of antiretroviral therapy, might help them as well. All right, babesiosis caused by Babesiosis microti. It's a zoonotic disease. This one is tick-borne, and it creates a malaria-like illness. Have you guys talked about malaria in any class yet? Pathology a little bit probably, or microbiology? Yeah, so you started it. We'll talk about malaria a little bit more next week for this class. So malaria, what vector is malaria? Mosquito, right? So if you have a malaria-like illness and it's high on your differential, and you tease out that they got bitten by a tick instead of mosquitoes, that might lead you down the road of babesiosis instead of malaria. Another histolytic type of situation. So these blood cells that break up can cause a lot of pain in the spleen, the kidneys, liver, etc. So similar symptoms as malaria, and it can be paroxysmal as well. People get chills and fevers, sweating, and then there's some prostration, and then it can remit and then come back a little bit. If they do have a history of splenomegaly from this or something else, then typically a worse outcome is more likely. Not a lot of physical exam findings. Some people will be jaundiced or have a splenomegaly because, again, all of those broken down cells are being collected and tried to be cleared by the spleen, so it might swell on them. GEMSA stain, some serology. If you do a CBC, you might see some thrombocytopenia, some anemia. And the ESR being elevated, that just tells us the lab is open. I'm sorry, I like that joke. I should stop saying it. You've heard it enough. And it's a malaria-like illness, and look, we're using some malaria-like medication treatments. Atovaquone, clindamycin, azithromycin, quinine, all of those can be used in combination to fight babesiosis. All right, I think I got you out of here 2 minutes before my goal. Did I go too fast?
Perfect.
Just like IPAP, it's figure outable, right? Yeah, figure outable. All right. I will just kind of hang out here for questions if there are. If not, have a great day. How'd the test go today?